So I'm pleased to now introduce Griffin Weber. Griffin is Associate Professor of Medicine and Biomedical Informatics at the Beth Israel here in Boston and Harvard Medical School. He is faculty lead of Harvard's Clinical and Translational Science Award, or CTSA, the informatics program there, and he's helped develop informatics for integrating biology at the bedside, I2B2, which he'll talk a little bit about, an open source platform for query and analysis of clinical data, and the Shared Health Research Information Network, SHRINE, which connects I2B2 and OMOC databases across organizations to form federated research data networks, which is what he's going to talk to us about today. Thank you, Griffin, for joining us.
All right, thank you so much for the introduction. I'm happy to be here. Some quick acknowledgments and disclosures, and also thanks to Niteesh and others for inviting me today. I'd like to start out with this sort of busy diagram that we published a decade ago, trying to map out all these sources of data about patients' health. The different rows correspond to different data domains like diagnoses and medications, all the way up to social determinants of health and environmental factors. The blue boxes represent data in the electronic health record. They're very deep. They have data about all these different domains. There's clinical notes, images, many other data types about patients, but they only represent small slices in the patient's history. It's when the patient is at the hospital or seeing a clinician, and you don't know anything about the patient's health outside of that healthcare system. Purple represents medical claims. Claims track patients as they go between different hospitals, but it's really billing codes. You don't get that rich depth of data that you see in the electronic health records. And then a lot of information about patients' health is just not in the healthcare system. For example, there might be credit card memberships to fitness centers that are on the credit card history. People blog or tweet about their health. When you're doing a study, you don't have to find all these different data sources. You pick which kind of information you need, and then you think about which types of data you have access to and how you may be able to link them together. So I'm going to focus mostly on electronic health record data. So I've helped for the last 20 years develop this open source platform called Informatics for Integrating Biology in the Bedside, or I2B2. It's a simple user interface website that any investigator at a hospital can use to be able to query patients within that hospital's electronic health record system. This was funded by an NIH grant for a decade. It was led by Isaac Kohane, and now there's a community of people who develop on this platform, and it's supported by something called the I2B2 Transmart Foundation. Users can drag and drop in inclusion and exclusion criteria, and without IRB approval, you can get a count of the number of patients who meet those conditions. And then with IRB approval, you can download the patient-level data that represents that cohort. I2B2 has been very widely adopted. It's used at hundreds of institutions worldwide. More than 150 million patients are in different I2B2 instances. So a lot of the work that I do is connecting these I2B2s or other data sets to create federated networks that can be used for research. So one of these is the Shared Health Research Information Network, or SHRINE. This is a real-time federated network. What that means is investigators get a website, they drag and drop in what they're looking for, and then they hit go, and the query is distributed out to all the different I2B2 sites. It's run locally automatically, and immediately they get counts back from all the different institutions. So this is a self-service tool for investigators to be able to search across the country on different electronic health record systems. There are different SHRINE networks. The biggest is funded by the NIH, called the ENACT network. It has 48 clinical translational science award institutions with over 100 million patients in there. One of the things that you need in order to get one of these networks to work is called common ontology or common data standards. So we map the local codes within each hospital to these data standards, which are used for the queries when they're broadcast out to all the different sites. This real-time network that I helped develop is in contrast to another network, which is much more manual, called the Consortium for Clinical Characterization of COVID-19 by EHR4C. So this was at the beginning of the pandemic in March 2020. We reached out to all the different sites that were using I2B2 and SHRINE and said, can we meet up and figure out if we can do some rapid analyses related to COVID? At that time, there weren't codes in the database for COVID. It was very hard to find patients. Patients were very rare still. We weren't sure how to categorize severe disease. So we didn't have the capabilities within the standard ITB2 Shrine tools to answer these questions. But we grabbed the local teams that we had each site. These included the informatics people, the statisticians, and we also pulled in the doctors who were seeing these patients. And we did some rapid analyses where instead of going through a website, we developed code, statistical analyses that we sent to each team. Each team ran the results locally and then shared the aggregate results back together, and we reviewed it as a group. This process worked very rapidly because we already had the infrastructure in place. Our first preprint that was in 4 weeks, and we've had a couple dozen papers that came out of it since then. There are two types of 4C analysis that we did. The first one we called phase 1. These are really basic questions. Just how many patients did you have? How many severe patients? How many were in ICU? These are just basic queries that were easy for sites to run. It was low barriers to participation, so we can get lots of institutions to help us with this. At the peak, we had over 300 institutions across 8 countries. Phase 2 studies, we looked at all the phase 1 sites and we picked the best ones that had the best data and had the capabilities to do it. And then we would send more complex analyses to those sites where they would need to extract patient level data from their EHR, maybe do some manual chart review with clinical notes and run machine learning models. It was still only aggregate counts, though, that we shared back. And we iterated back and forth between these phase 1 and phase 2 studies to do these analyses. So I talked about 2 different kinds of federated networks that I've been involved in creating, the more automated one with Shrine and the more manual one with 4C. But there are lots of different national networks that are out there. We heard about all of us, and I'll talk about a few others. There's a network called the Odyssey Network that's structured very much like 4C, but they're focused more on sites that are using the OMOP data model rather than the ITB2 data model. There's a network of networks called the BacorNet, our network has about 60 plus million patients in that. There's a commercial network called Trinetics. So this is usually pharmaceutical companies subscribe to Trinetics and can similarly run aggregate count queries in real time across many different institutions to try to find sites where they can partner with clinicians or researchers to run clinical studies. The opposite of the federated networks are centralized databases. So sites take data out of their EHR and all pull it together in a central location. So one of the big ones during the COVID pandemic was the NIH-funded National COVID Cohort Collaborative, or N3C. Sites from all these different networks that I talked about, the federated networks, many of them contributed data to that N3C central repository. Has over 20 million patients there. An advantage of the central repository is that you can go into one place and it's easier to do machine learning types of analyses. You can still do it in a federated network, but it's more complex in that way. Also, what N3C did was create what's called a synthetic derivative. So you create a fake data set that has similar statistical properties to the real patient data. And that allows you to share the synthetic data set more broadly than the patient data, which has more privacy issues. Many hospitals across the U.S. use Epic, and Epic also has its own central database. So if your hospital opts in, Epic, a hospital will send all their Epic data into the central Epic database. It has data from 1,600 hospitals, almost 300 million patients. And again, it's a great environment that has all various statistical tools and database software to help you analyze that massive amount of data. So these things aren't really competing against each other. They all serve different purposes. They're complementary and synergistic to each other. All the way on the left is the 4C network. This is the one that was very manual. You had teams of informatics, statistics, and clinicians. It's not very scalable because of the amount of work that's involved, but you need it sometimes to figure out the data quality issues, figure out what codes are used, and work out really complex problems. The Shrine and NACT network, which is kind of next, enables you to roll this out to many investigators. So we have thousands of people who use your NACT network to do research questions. You can do large population analyses there. What you lose in an NACT is that if there's something weird that seems in the data, you don't have that ability to go and dive in and ask the clinicians questions. You kind of have to accept the counts that you're getting from the network. In N3C, you have that advantage of all the data is in one place. But when you pull data from many different institutions, you lose the site variability, and that's important. Sites have different patient populations, they have different standards of care, different laboratory tests they use. When all that gets kind of mushed together, you lose a lot of important signal. And then finally, when you generate the synthetic data, you've lowered the barriers to accessing it. You can even make some of that data public. But you are intentionally removing the rare events because they might be identifiable. So there's only certain types of research questions that work well in the synthetic data, and then other times you have to go back to the real patient data. None of these tools will help you if you're dealing with data quality problems. So I'm going to talk a little bit about EHR data quality and completeness. And a point I'm going to try to make is that it's not really data quality that's going to ruin your analyses. It's more about how data are collected in electronic health records. And if you're aware of that, you can adjust your analyses appropriately to actually take advantage of this. So one thing is about data completeness. Patients receive care at multiple institutions so that at any one electronic health record system, you're probably missing a lot of the data about those patients. It's not that they lost the data, it's just patients go to different sites. So that's not what the purpose of the electronic health record is. We can use machine learning models, though, to try to predict which patients have more complete data in the EHR. There are many factors. One of the ones I find interesting is the number of visits that a patient has at a hospital. If a patient has a single visit at your hospital, there's a chance they're just a very healthy patient, and that's the only time they ever needed to go to the hospital. But that's rare. Most of the patients with one visit are really patients at another institution that may have stopped by your hospital once in an emergency room, and you're really missing the majority of their data. There are patients at the other end who might have 100 visits over a multi-year period at your institution. So there are clearly patients who are mostly being seen at your site, but these really sick patients almost always have gone somewhere else also for some kind of care or test. The patients who are most likely having complete data are in kind of the middle. They have a few visits a year, their routine checkups, some screening tests, but those patients are healthier than normal. So you get biases when you're trying to pull out those patients who have more complete data. Another kind of question is which patients have a medical condition. Every time a patient is seen by a doctor, some diagnosis code has to be entered in for billing purposes. So, for example, half the patients with a code for diabetes don't have diabetes. They're being tested for diabetes. So patients end up with all these codes in their chart, and they don't really have those diseases. This has an impact, for example, when you're looking at clinical trial feasibility, and you may think there's a large cohort of patients who match your study criteria, but a lot of those patients have sort of fake codes and you may end up not reaching those targets. So to address these, we generate something called computed medical conditions. The raw diagnosis codes have low precision. Not all the patients with those codes have the disease. So the typical way you do this is called rule-based phenotypes. You get a group of clinical experts together and you come up with a set of logical flowcharts or rules, like the patient has had 2 visits for diabetes and they're taking insulin and other things, and that'll help you classify the patients. But these are slow and expensive to develop. Only dozens of diseases have these rule-based phenotypes out of thousands of different diagnoses. So what we're using today in I2B2 are probabilistic phenotypes. We're using artificial intelligence and machine learning to generate probabilistic models that say the likelihood that a patient has the condition based on all the data in their chart. We use a couple different algorithms to do this. The first one is something called embedding regression. It's like what large language models use. It looks at all the data in electronic health records to discover that, for example, type 2 diabetes is often mentioned in the context of insulin and hypertension and obesity. So it learns features that are present in patients with diabetes. That model doesn't create a statistical model that helps you assign probabilities to patients. That's the next step. Then we take the features from the embedding regression and assign weights to them. Things with positive weights are evidence that the patient has a condition. Things with negative weights are evidence that the patient may not actually have that disease. We can generate these models for thousands of different diseases. We run them across millions of patients and enter the patients who we think really have the conditions into the I2B2 system. And you can query that and get much more accurate results. And then the last question I'll ask to the EHR is which patients are healthy? We saw before just asking, does a patient have one visit? And you might think they're healthy, but those are actually patients who are not at your institution. Another thing I can look at is laboratory tests. So what this study showed that patients with a normal white blood cell count at 3 in the morning have lower survival rates than patients with an abnormal white cell count in the afternoon. And it sounds counterintuitive that the normal test result patients are dying more. And it turns out that the only patients who are getting laboratory tests in the middle of the night are really sick patients. And it doesn't really matter what the value is. You know that they're in a poor state of health. In the afternoon, by definition, 5% of healthy patients are outside the reference range for a laboratory test. So all those patients who are coming in for an annual checkup, getting these abnormal test results, and they have a higher survival rate. We looked at hundreds of different laboratory tests. And for the majority of laboratory tests, the time of the day of the week, or the time interval between tests is more predictive of survival and 30-day readmission rates than the actual value of the test. So this enormous amount of data about how physicians view their patients, the physician behavior, how the patient is being moved around different hospitals is very highly predictive, but we often overlook that. We're focused usually in electronic health records on what's the diagnosis code, what's the laboratory value, but we're not thinking about these different healthcare processes and how they influence the data that are in EHRs. So in summary, EHRs have a lot of very rich data for potential for research. Accessing EHRs from multiple institutions increases your sample size and can build confidence in the findings. There are lots of different approaches for collecting data from different sites' electronic health records. You really have to pick the one that matches your research question and objectives. And then finally, when people talk about electronic health record data quality problems, what you really have to do is think about healthcare system processes, how they lead to those apparent data quality problems, and ways you can use artificial intelligence and machine learning to address that and actually use it to your advantage. So thank you.